We'll be moving to session 3, and this session will be chaired by Oloko. That will be chaired by Professor Oloko and ably assisted by Dr. Oladipo. And our guest speaker is Professor Alicia Wade. She's online, and she'll be joining us and presenting virtually. And before she presents,
distinguished senior colleagues and colleagues, welcome to this very important session. To present the citation of Professor Alicia Wade, we would like to call Dr. Adeolu to please come forward. Please put your hands together.
Good day, sirs and ma'ams. It's a great privilege and honor to be reading the citation of Professor Alicia Wade. Professor Alicia Wade is the Director of Research in Metabolism and Endocrinology at the University of Witwatersrand in Johannesburg, South Africa, and a reader and clinician scientist in the Department of Internal Medicine in the School of Clinical Medicine at the same institution, as well as an adjunct associate professor in the Division of Endocrinology, Diabetes and Metabolism in the University of Pennsylvania. A native of Barbados, she graduated from the University of West Indies in the year 2000 as a clinical gold medalist and with MBBS honors degrees. Proud to attending the University of Oxford as a Commonwealth Caribbean Rhodes Scholar and graduating with a Doctor of Philosophy degree in clinical medicine. She then completed a residency training in internal medicine at the John Hopkins Bayview Medical Center and a fellowship in endocrinology, diabetes, and metabolism at the University of Pennsylvania, both in the United States. She was awarded an Emerging Global Leader Career Development Award from the Fogarty International Center at the National Institute of Health, USA, and has published over 85 peer-reviewed articles. Her research focuses on health equities in endocrine and metabolic diseases. She is an active clinician and sees patients with endocrine diseases at the Donald Gordon Medical Center in Johannesburg. Please, with a round of applause, let's welcome Professor Alicia Wade.
Thank you so much for that kind citation. I'm just going to turn off my video because I can see there's a little bit of a lag. And then I am going to share my screen, and I would just appreciate confirmation that you can see it with no difficulty before I begin. And if someone can just confirm that my screen is visible?
Yeah, you're quite visible. You need to put it on slideshow. We're good.
Yes, I'll do that. I just wanted to make sure that you could see it first. So thank you again for the kind citation, and thank you again for the invitation to present to this conference. This is the second time I'm speaking to a Nigerian organization. I spoke at the World Thyroid Day a little earlier this year, and I really look forward to being there in person sometime to share some of the work that we're doing. So, as you heard at the beginning, I'm going to be speaking today about cardiovascular complications of thyroid disorders. I did tune in just towards the end of my predecessor's presentation, and I saw that she was privileged to be able to present lots of randomized controlled trial data to you. Unfortunately, we don't have that benefit in thyroidology. There is less and less interest, unfortunately, in thyroidology, possibly because a lot of the drugs are now off patent and the opportunity to make money for new indications is not there. So unfortunately, the kind of financial support that's necessary to do large-scale randomized controlled trials really isn't there. So a lot of the data I am going to be discussing will be from some observational trials, and where there are data from randomized controlled trials, I'll be sharing that with you as well. So just to begin, I think it's important to realize that thyroid hormones have a very complex relationship to the cardiovascular system. And this operates really through multiple mechanisms. So their main effects are observed on the heart, the vascular tree, as well as direct effects on cardiovascular risk factors. Thyroid hormone directly influences the heart rate, the rhythm, and myocardial contraction, as well as the risk of coronary artery disease. In the blood vessels, thyroid hormone can affect blood pressure through regulating smooth muscle tone and endothelial function. And then there's also an effect on lipid metabolism and a modulation of inflammatory pathways. One of the primary sites of action of thyroid hormone, as I mentioned, is the heart. And it has both genomic and non-genomic actions on the cardiomyocyte. So T3, triiodothyronine, enters the cardiomyocyte through membrane transporters. And it's also produced in the cardiomyocyte by the conversion of T4, from the conversion of T4 by type 2 DIAO2. And then that T3 then binds to the thyroid hormone receptors in the nucleus, and that in turn regulates transcription by binding to thyroid hormone response elements, which are present in the regulatory areas of the target genes. DIAO3 breaks down both the T3 and T4 and terminates the action of these hormones. And there are numerous genes that are positively regulated by thyroid hormone. And those include some that encode for the myosin heavy chain and sarcoplasmic endoplasmic reticulum calcium ATPase, as well as genes that are negatively regulated, including those that encode for myosin heavy chain beta and PLN as well. Now, in addition to those genomic actions, there are also several non-genomic actions that T3 has within the cardiomyocyte. And these include regulating the voltage-gated potassium channels, the sodium-potassium ATPase, and the sodium-calcium exchanger, as well as activation of survival pathways. So how do these myocardial and vascular effects translate to hemodynamic changes? So T3, which is really the biologically active form of thyroid hormone, works via numerous mechanisms to increase cardiac output. So there's an increase in the systemic vascular resistance that occurs as a direct effect of T3, as well as due to increased thermogenesis, which is also caused by T3. And this decrease in your systemic vascular resistance results in a decreased effective arterial filling volume, increased renal sodium reabsorption, and increased blood volume. And that then contributes to increased cardiac inotropy and chronotropy and leads to increased cardiac output. Now, both T3 and the decreased vascular resistance also contribute to the increased inotropy and chronotropy, and therefore to the increased cardiac output as well. So, as I mentioned, thyroid hormone also has an effect on lipid metabolism, but it actually does so in contrasting ways. On the one hand, it increases the hepatic cholesterol synthesis by inducing the HMG-CoAs reductase. On the other hand, it increases the LDL receptor gene expression in the liver. It increases the cholesterol ester transfer protein concentrations, and this facilitates moving triglycerides from the LDL. And it also increases hepatic lipase concentrations, and that facilitates clearing triglycerides from the LDL and IDL. It also increases the action of 7-alpha hydroxylase within the liver, and that converts cholesterol into bile acids for excretion. In addition, it also increases LCAT, which esterifies cholesterol, transports it out of the blood and tissues into lipoproteins. And further, it also decreases intestinal cholesterol absorption. So the net effects of these contrasting effects of thyroid hormone on cholesterol metabolism is to lower LDL. And in fact, there have been some attempts to try to replicate this in terms of producing pharmacologic agents. So there's been attempts to develop dextroisomers of thyroxine. So you know what we use commonly in clinic is L-thyroxine. There have been attempts to create D-thyroxine, a dextroisomer of this, as well as trying to create drugs which are hepatic-specific LDL receptor agonists to try to improve the uptake of the hepatic uptake of LDL. Unfortunately, these drugs really have never made it through to market. Reason being, first of all, with the dextro isomers, they had unacceptable cardiac side effects, and the LDL receptor agonists resulted in hepatic injury. So they were really never viable for drugs that had commercial potential. So having discussed the physiology of thyroid hormone and the cardiovascular system, what kind of changes do we see in cardiovascular indices in thyroid dysfunction? So first of all, if we look at hyperthyroidism, we can see that the heart rate, not unexpectedly, because now we've looked at what happens and the effect intracellularly on the cardiomyocyte of thyroid hormone, we can see that in patients with hyperthyroidism, as we all know clinically, usually experience an increase in heart rate, whereas conversely, those with hypothyroidism usually have the opposite. Systemic vascular resistance is usually decreased in hyperthyroidism, as we mentioned, whereas in hypothyroidism, the converse happens and we have that increase. Ejection fraction increases in hyperthyroidism, decreases in hypothyroidism, and cardiac output, both measured in terms of liters per minute as well as a percentage of normal blood volume, is increased in hyperthyroidism and decreased in hypothyroidism. And last but not least, the relaxation time is also decreased in hyperthyroidism and increased in hypothyroidism, which is not unexpected, particularly given the increase in the heart rate. Now, having had the chance to review some of the physiology, I'd like to review some of the common cardiovascular complications in people with thyroid dysfunction. And I've chosen to focus on dysrhythmias, hypertension, atherosclerotic cardiovascular disease, and heart failure. So dysrhythmias are extremely common presentations in people with thyroid dysfunction. In hyperthyroidism, arresting tachycardia and an exaggeration of the kind of normal exercise-induced heart rate that we normally see are very, very common. And these changes that occur in hyperthyroidism are due to an increase in the sympathetic tone, but also a decrease in the parasympathetic tone. Now, while the most common tachyarrhythmia we see in hyperthyroidism is a sinus tachycardia, atrial fibrillation gets a lot of attention, and reason being, and probably quite appropriately, is because of the potential complications, including the embolic phenomena that can occur with atrial fibrillation. And in people with overt hyperthyroidism, we see atrial fibrillation in about 5 to 15%. I'm just going to pause there before I go on. I'm going to be using the terms overt and subclinical hyper and hypothyroidism. I'm sure this audience is quite familiar with them. But just in the event there's anybody in the audience who's not as familiar with those terms, overt hyperthyroidism is defined by someone who has a decrease in thyroid stimulating hormone and who also has a concomitant increase in thyroid in free thyroxine, whereas subclinical hyperthyroidism is someone who has a decrease in their thyroid stimulating hormone but does not have an increase in their free thyroxine. Similarly, overt hypothyroidism, you have an increase in thyroid stimulating hormone and a decrease in free thyroxine. And subclinical hypothyroidism, there is an increase in thyroid stimulating hormone but a normal free thyroxine. So just having mentioned that, I do want to mention that in overt hypothyroidism, other atrial and ventricular tachycardias are uncommon. So if you have someone who's presenting, for example, with atrial flutter or paroxysmal SVT, you want to make sure that you're looking for any other potential causes besides hyperthyroidism. And that search should also include evaluation for any underlying structural problems. So even though I did mention that atrial fibrillation is quite common in people with hyperthyroidism, fewer than 1% of the cases of new onset atrial fibrillation are going to be due to overt hyperthyroidism. And in fact, the finding of atrial fibrillation in the absence of any other features of hyperthyroidism is actually rather uncommon. Fortunately, we do know that if we can induce these people with hyperthyroidism to revert to euthyroidism, we can usually precipitate a reversal to sinus rhythm in about 60%. But not everybody is going to revert to sinus rhythm. And people who are older and who have a longer duration of atrial fibrillation are less likely to revert to sinus rhythm. So conversely, sinus bradycardia is the most common dysrhythmia in hypothyroidism. And as I mentioned a little bit earlier, ventricular dysrhythmias are unusual in hyperthyroidism, but because hypothyroidism prolongs the QT interval and predisposes to cardiac irritability, you can see ventricular arrhythmias, and very occasionally torsade de pointe can also occur. The second thing I'm going to move on now to discuss is systemic hypertension. So hypertension is very common in our populations generally, and the majority of people you're going to see with hypertension are not going to have hyperthyroidism. But having said that, systolic hypertension does occur in about 30% of individuals with hyperthyroidism. And the balance between the increased cardiac output and the decreased systemic vascular resistance really determine how high that blood pressure increase is going to be. Now, conversely, overt hypothyroidism is associated with diastolic hypertension. And in fact, diastolic hypertension is seen in about 10 to 25%, of people with overt hypothyroidism. And this is possibly due to the increased systemic vascular resistance and arterial stiffness, the endothelial dysfunction, and low renin levels. But once again, hypertension is unlikely to be the only presenting clinical feature in people with hypothyroidism. In addition to systemic hypertension, pulmonary hypertension can also be a finding in people with thyroid dysfunction. And most commonly, what we see is pulmonary hypertension and hyperthyroidism. And in fact, this can affect somewhere between 43 to 44%. Now, it's not clear whether what we're seeing is simply an association or if the hyperthyroidism is actually causative of the pulmonary hypertension. Some of the postulated mechanisms for potential causation include left ventricular heart failure, hyperdynamic circulation, and endothelial cell proliferation. And perhaps in some further evidence for causation, there have been observational studies in which individuals with newly diagnosed Graves' disease have seen resolution of their pulmonary hypertension after they have been rendered euthyroid. Now, both hypo and hyperthyroidism are associated with atherosclerotic disease risk factors. So in patients with hyperthyroidism, there is a mild reduction in their lipid parameters. As I mentioned, there is systolic hypertension, and we do see a widening of the pulse pressure. There's also excessive endothelial nitric oxide production and exaggerated vascular reactivity. There's also, on the arterial side, increased arterial stiffness and CIMT thickness, particularly if disease is long-standing or untreated. There is increased risk of thrombogenesis with increased fibrinogen and von Willebrand's factor in overt disease. And then, as we discussed, there's the increased risk of atrial arrhythmias, as well as increased atrial size, left ventricular mass, and impaired diastolic function if disease is long-standing and untreated. In hypothyroidism, on the other hand, we know we've got this increased total cholesterol and LDL cholesterol, and we discussed the underlying pathophysiology of that. There's the diastolic hypertension as well, which I mentioned. And we also know that there's impaired endothelial-dependent vasodilation and increased arterial stiffness. The effect of hypothyroidism on thrombogenicity is less clear, and we do know that there's both left ventricular systolic and diastolic dysfunction at rest and during exercise in patients with hypothyroidism. So observational studies have documented a higher risk of ischemic heart disease, particularly in overt hypothyroidism, but it's very difficult to quantify. As you can imagine, given the fact that there are multiple other indications for treating people with overt hypothyroidism, it really would not be ethical to withhold treatment and do a randomized controlled trial in which some people with hypothyroidism were treated and some people weren't, in order to evaluate what the effect on ischemic heart disease is. So really, we are limited to using observational data in this regard. And because people with hypothyroidism, particularly in better resource countries or countries which are not, which don't have resource constraints, often started on thyroid hormone very early in the course of their disease. So there's less and less opportunity for us to observe what the potential ramifications on atherosclerotic cardiovascular disease happen as a result of hypothyroidism. Now I'd like to spend some time discussing hypothyroidism and heart failure. So heart failure is really multifactorial, and there are multiple points at which heart failure can be worsened by low thyroid function. So low thyroid function can reduce your cardiac function and output, and it induces morphological, molecular, and structural changes in the myocardium. It also, as we discussed, increases your peripheral vascular resistance, the plasma noradrenaline concentrations, and plasma renin activity, leading to increased sodium retention and reduced erythropoietin. And as a result of it, these can all precipitate heart failure. And having looked at this and understanding again what some of the pathophysiology is vis-a-vis thyroid hormone and heart failure, there are ongoing clinical trials, particularly to evaluate the effect of supplemental T3 or exogenous T3 in patients with heart failure. But these trials have yet to report, and so it's really not clear whether or not T3 has a role in treating these patients. So hyperthyroidism can also lead to heart failure, particularly if it's been long-standing or severe. Usually, if heart failure does result in patients with hyperthyroidism, it's usually due to left ventricular hypertrophy, arrhythmias, or the increase in preload, which is due to the volume overload. And we just discussed a little bit about how that can happen. Persistent tachyarrhythmias can also contribute, and sometimes this manifestation of heart failure is rate-related. And if heart failure does occur, it can be particularly severe in patients who have underlying ischemic or hypertensive heart disease, because they really cannot respond to the increased demand that results from the increased metabolism in patients with hyperthyroidism. So we've spoken a lot about overt hyperthyroidism and overt hypothyroidism in the heart. And I mentioned a little bit earlier how we make those distinctions between subclinical and clinical and overt thyroid dysfunction. So what about people with subclinical thyroid dysfunction in the heart? And is there any data to really suggest that this matters? So we do know that there is an effect of subclinical thyroid disease on cardiovascular risk factors. So we're not talking about the overt now. We're talking about people who have this biochemical anomaly, which has the misnomer of subclinical thyroid dysfunction. And we really want to understand, well, what impact does that have on cardiovascular risk factors? So today, the data suggests that people with subclinical hyperthyroidism really have no effect on their lipid parameters. There is a possible increase in their diastolic blood pressure, and there does seem to be some higher carotid intima media thickness, so some evidence of endothelial dysfunction. Like their counterparts with overt hyperthyroidism, there is increased fibrinogen and therefore increased thrombogenicity, and they too have an increased heart rate and increased left ventricular mass. Patients with subclinical hypothyroidism, like their counterparts with overt hypothyroidism, also have increased serum levels of total and LDL cholesterol and diastolic hypertension as well. They too have impaired endothelium-dependent vasodilation and increased arterial stiffness, and also left ventricular systolic and diastolic dysfunction. As with patients with overt hypothyroidism, the effect on thrombogenicity in subclinical hypothyroidism is really quite unclear. So having seen these data and understanding that there is an underlying effect on risk factors, what then are the potential implications for cardiovascular outcomes? Because we know obviously one can generate risk factor data, but it's important to know that if one intervenes, is there a likelihood of actually affecting outcomes? So this slide shows some data from patient-level meta-analyses which have been conducted in multiple cohort studies. So the data from the coronary heart disease, events, mortality, incident atrial fibrillation, all come from a study that was done in a meta-analysis of over 10 cohort studies that included over 50,000 people, and they're adjusted for age and sex. And then the data from the heart failure events are derived from just over 25,000 people in 6 cohort studies. And what you can see in this is that in individuals with subclinical hyperthyroidism, there was really no statistically significant benefit in coronary heart disease events. So the hazard ratio was 1.21, but it wasn't statistically significant. There was, however, an improvement in coronary heart disease mortality. The hazard ratio there was 1.29. And also, more pronounced, there was a benefit in incident atrial fibrillation. So in these patients, observational studies, meta-analysis, in patients who had subclinical hyperthyroidism were 68% more likely to develop incident AFib. There were also data looking at the heart failure events, and what this showed is that in patients who had a TSH of between 0.1 and 0.4 international units per liter, there was really no significant increase or a significant hazard of heart failure events, but in patients who had a lower TSH, so an undetectable TSH, were almost twice as likely to have incident heart failure. Similar studies, observational studies, meta-analyses, have also looked at subclinical hypothyroidism and cardiovascular outcomes. So again, the data from the coronary heart disease comes from a patient-level meta-analysis of 11 cohort studies, also including over 55,000 people. And what you can see is that when one looked at the TSH broadly, so everybody who had subclinical hypothyroidism, which was defined in the study as a TSH between 4.5 and 19.9, there was really no overall risk of coronary heart disease events or, in fact, coronary heart disease mortality. However, if one stratified the analyses and looked at them depending on the level of TSH, you can see that there is some information emerging. So in patients who had a TSH just above the normal range, so between 4.5 and 6.9, and those who had a TSH between 7 and 9.9, there was no increased risk of having a coronary disease event. However, in patients who had a TSH of greater than 10, they had an 89% higher likelihood of having a coronary artery disease event compared to patients who were euthyroid. In patients, when we looked at coronary heart disease mortality, what we see again here is that in patients who just had a slight elevation in TSH, so TSH of between 4.5 and 6.9, there was really no increased risk of coronary heart disease mortality. However, when the TSH was between 7 and 9.9, there was an increased risk of 42%, and in patients who had a TSH of between 10 and 19.9, the risk was even higher at 58%. Similarly, when we looked at the risk of heart failure, there was no significant increase in heart failure events in patients who had a TSH between 4.5 and 6.9, or between 7 and 9.9, but there was a definite increased risk in patients who had a TSH of above 10, with an increased risk of 86%. Now, these data are particularly important, I think, in our sub-Saharan African context. The reason for that is we actually have no normative data on the distribution of thyroid-stimulating hormone in sub-Saharan Africa. And if you remember, our definition of thyroid disease very much depends on what that TSH is. And it's even more important in subclinical thyroid dysfunction, in which you have a normal 3T4. So you're really depending just on that abnormal TSH to make that diagnosis. And we know from work that we have done and work that others have done as well, that the population shift in thyroid-stimulating hormone is actually different in people of African ancestry. It's actually shifted to the left. And therefore, in the absence of normative data on how we define thyroid disease, we run the risk of defining people in sub-Saharan Africa as having thyroid dysfunction when in fact they don't have thyroid dysfunction. So we run the risk of overdiagnosing hyperthyroidism and actually underdiagnosing hypothyroidism. And that's something which myself and my colleagues are actively working on, trying to generate this kind of data so we can look at our definition compared to what is used internationally and really define whether or not we need to be looking at different thresholds for making these diagnoses. So what do we do in terms of identifying cardiovascular disease in a patient with thyroid dysfunction? So you've got a patient in front of you in clinic, they've got, overt hypothyroidism, overt hyperthyroidism. How do we identify cardiovascular disease? And here, your clinical history and exam are your best friend. As I mentioned earlier, cardiovascular disease is unlikely to be the only manifestation of overt thyroid dysfunction. So taking a good history and a good exam is going to be critical in identifying the patient who has a dysrhythmia, identifying the patient who has heart failure, or identifying the patient who may be at increased risk of atherosclerotic cardiovascular disease because of the presence of thyroid dysfunction. Now, what do we tell our cardiology colleagues about identifying thyroid dysfunction in a patient who's got cardiovascular disease? So I mentioned earlier, for example, prevalence of hypertension in sub-Saharan Africa is, depending on the population, maybe as high as 60%, if not higher. So it's really not practical or cost-effective to be checking thyroid function in everybody who comes to your clinic with systemic hypertension. But obviously, there are some features which should make you more suspicious for thyroid dysfunction and should prompt as that screening with TSH. So certainly any patient who has an unexplained bradyarrhythmia or tachyarrhythmia should have their TSH checked. If the patient has significant hyperlipidemia, we should definitely rule out hypothyroidism as an underlying secondary cause. Patients who have a new onset failure should be screened for thyroid disease, if only because we know optimization of thyroid function may, if they have overt thyroid disease, improve their outcomes. And patients who have unexplained pericardial effusions, because pericardial effusions can be present in maybe 3 to 5% of patients with hypothyroidism. Again, hyperthyroidism is a little bit tricky, a little bit less tricky because it is more likely to present with obvious clinical features. As we know, hypothyroidism can often be very difficult to detect clinically because the features are so nonspecific, but hyperthyroidism is much more likely to have obvious clinical features. But we must remember the older patient who may present with hyperthyroidism but may have atypical features which may not be obvious, and in those instances we need to make sure we have a high index of suspicion. So how do we manage thyroid dysfunction in cardiovascular disease? Fortunately, the cardiovascular symptoms of hypothyroidism do resolve with restoration of euthyroidism. We do need to be careful when we're starting particularly older patients or patients with known ischemic heart disease on thyroid hormone replacement, because what we don't want to do is increase that metabolic demand and have the myocardium incapable of keeping up, and neither do we want to precipitate ischemic heart disease event in someone who may have non-critical blockages or may have some myocardial flow restriction. And we increase that myocardial demand by increasing contractility and then precipitate an event. So the gold standard for hypothyroidism remains levothyroxine. I think, as I said, there are some trials going on trying to understand the role of liothyronine in heart failure, but certainly for hypothyroidism, the gold standard remains levothyroxine. And obviously, you want to clinically assess your patient, and they may require additional specific therapy, such as diuretics for heart failure, if the clinical situation warrants. So similarly, the cardiovascular symptoms of hyperthyroidism will also often resolve when the patient becomes euthyroid. As I mentioned, there are some factors which may make the patient persistent. So if there are underlying structural issues, the patient is older, or they've had AFib for a long time. But it is very important to make sure we restore that patient to euthyroidism before we try to cardiovert them. Because if they remain hyperthyroid, chances are they're going to revert to dysrhythmia. Again, you may need to do, rate control that patient with beta blockade before you give them definitive hyperthyroid treatment, and that's often quite common. And once more, we need to treat the whole patient and not just the thyroid disease. And what about subclinical thyroid dysfunction? So again, this is where I'm very jealous of my colleague who presented earlier, because we have very little trial data to really guide practice vis-a-vis subclinical thyroid dysfunction. There was a recent retrospective cohort study that was done in just over 300 people in Canada, and that showed a trend toward lower prevalence and incidence of atrial fibrillation in people who were treated for hyperthyroidism versus people who weren't. But again, that finding, in addition to some of the findings I presented to you earlier, have really led to the recommendation that in patients who have a TSH that's undetectable in subclinical hyperthyroidism, they should be treated. Or if their TSH is between 0.1 and 0.5 and they have risk factors such as older age or existing cardiovascular disease. Now, it would seem almost obvious, or that since we know that hypothyroidism has particular cardiovascular effects, it may seem given that by treating the hypothyroidism, we can reduce those cardiovascular events. And this is an instance where we do have some trial data, though the studies were fairly small, in which levothyroxine was given to older adults with subclinical hypothyroidism. Unfortunately, there was no improvement in atherosclerosis or systolic or diastolic function. So as yet, there are really no data to support treating patients with subclinical hypothyroid function for these indications. So take-home points today. So thyroid hormone has protein effects on the cardiovascular system, and we know that treatment of overt thyroid dysfunction, whether hypo or hyperfunction, can prevent or improve cardiovascular outcomes. However, additional work is still needed to understand whether the treatment of subclinical dysfunction improves outcomes. Thank you very much.
Thank you very much, Alicia, for that excellent delivery. Before we take questions and comments for the presenter, we'll take a quick wrap up. Are you ready? Okay, thank you.
Thank you very much. Good morning, everyone. So I'm going to give a quick recap of the lecture taken by Professor Alicia Wade, and with the topic cardiovascular complication of thyroid disorder. So she took us through a brief relationship of the thyroid hormones with the cardiovascular system, how that affects the rate, the readings, the blood pressure. She talked about the primary site of action of the thyroid hormones in the heart, the effect on the myocardium, and how that the T3 especially binds the thyroid hormones in the nucleus. She also spoke about the genomic and non-genomic actions of the thyroid hormones. She spoke to us about, we had a physiology of the cardiovascular resistance, how that it causes renal sodium absorption to increase blood volume and cardiac output. She spoke about the thyroid hormone, effect of thyroid hormone on cholesterol, and how some medications may affect that effect. Then she took us through the changes in the vascular system with overt hypo and hyperthyroidism, how that affects the rate, the ejection fraction, the relaxation time. Then she took us through the differences between the overt definitions of overt hyper and hypothyroidism, and how it is important to have a clear distinction of this definition as it affects our how we assess our patients. She also talked about the reversal to sinus rhythm, that how it is likely when we bring our patients to when they're euthyroid. Okay, so then she talked about the different effects of thyroid hormone on the cardiovascular system, involving the systemic hypertension, pulmonary hypertension, the left ventricular heart failure. So she spoke about the multifactorial cause of heart failure, but how we should consider thyroid hormones in assessing patients with heart failure. She spoke to the importance of assessing subclinical thyroid dysfunction and looking out for their effect on the heart too, as it's not only the overt thyroid dysfunction that will have effect on the lipid, the endothelial function, thromboembolic functions of the heart. So quickly to how to identify. Also, she mentioned that for now there's no normative data in sub-Saharan Africa about this and that. It would be nice for us to have a data for ourselves that we would work with. So how to identify thyroid dysfunctions? History and examination, she mentioned, are critical in identification, and she gave some reasons or indications for us to look out for thyroid dysfunction, including unexplained brady or tachyarrhythmia, systemic or significant hyperlipidemia, new onset heart failure, and unexplained pericardial effusion will be reasons why we should assess our patients for thyroid dysfunction. Okay, so in management, she said gold standard for hypothyroidism still remains levothyroxine, and that we should think to add other specific therapy as we think our patients might have need for them. So there's little data on need for subclinical treatment, but that it's important to assess our patients and see if necessary. So take home was that thyroid dysfunction has protein effect on the cardiovascular system, and that treatment of overt hyper or hypothyroidism is important to prevent or improve their outcomes. Thank you.
Thank you very much. We will take questions and comments. Then there will be a brief presentation of an appreciation plaque to our guest speaker. Let me just say a little about Alicia. We first met at a meeting some times ago in Abidjan, and we were on the same faculty presenting some talk with respect to thyroid disease and, on my part, diabetes in Africa. And since then, we've been quite close and we've been talking a lot. She has a passion for work and collaboration with Nigerian endocrinologists. In the coming months, I'm sure there will be something that we will bring to the table for willing members of EMSON to participate in. Alicia, we are very grateful. So we'll take questions and comments. Questions, comments? Any questions, comments, contribution? Okay. Alicia, I don't know if you could speak to apathetic thyrotoxicosis and cardiovascular disease. I know you talked a lot on subclinical. Maybe for the purpose of our younger colleagues, if you could just say a word or two about apathetic thyrotoxicosis.
Yeah. So thanks very much, Andrew. And yes, I'm just going to echo those sentiments that in my introduction, the young lady who introduced me mentioned that one of the things I really am passionate about is equity, and how we ensure that the representation of data and the data on which we base our clinical decisions is representative of the populations who we're treating. So I very much welcome the opportunity to collaborate. Yes, I do a lot of work in thyroid, but I also work in diabetes, and I'm also very keen to mentor and work with young people particularly who are interested in getting involved in research. Now, having said that, I did allude a little bit to apathetic thyrotoxicosis when I spoke about the elderly patients, because these are the patients in whom we normally see apathetic thyrotoxicosis. So we may, patients who come in may have, features such as weight loss. Sometimes they may have some cardiovascular features sometimes, but not necessarily so. But often one of the prominent features is weight loss or wasting. And in those patients who are elderly, we just have to have a very, very high index of suspicion. So obviously one of the things we think about in patients who are losing weight unexpectedly is malignancy. And obviously that is something that we have to obviously have a very high index suspicion for. But we have to just be sure that someone who's older comes in with some features such as apathy. They may have weight loss, they may have weakness, and they also have those cardiovascular features of, atrial fibrillation and heart failure. We have to think of hypothyroidism in those patients. They may not have other typical features like anxiety and, this almost kind of tremor. They may not have those features, but they may have other features which are suggestive. So we just need to make sure we have a very high index of suspicion in those cases.
So thank you very much. So can we appreciate her once more? Alicia, we'll appreciate if you put your video on.
Yes, my video is on.
Okay, thank you. We're going to do a brief presentation. We know you are with us virtually, but we'll get this across to you very soon. To receive this award, on behalf of Professor Alicia Wade, I would like to call Professor Rufemi Fasomade to stand in for Alicia, just very briefly.
You can see the resemblance.
Yeah. It's just that Alicia is not as grey as Professor Fasomade.
I don't know about that. The camera's doing me a favor.
So the Endocrine and Metabolism Society of Nigeria-EMSON presents this plaque to Professor Alicia Nicole Wade in appreciation of your role as guest speaker at our 46th Annual General Meeting and Scientific Conference, tagged EMSON Lagos 2025. Congratulations.
Thank you so much. Thank you to you, Andrew. Thank you, Professor, for receiving the plaque on my behalf. And as I said, it really is a heartfelt sentiment that I really look forward to future opportunities to collaborate, to work together and to see how we can advance endocrinology on the continent.
So thank you very much. Thank you for saying this. So this brings to a close this session. I'll hand over the microphone to Dr. Olokwade. Thank you very much for your wonderful participation.